So very good evening to all of you. And today we are going to conduct this 10th online teaching class under a banner of Up-Aroi chapter. So for this, I'm going to introduce Dr. Kailash Mittal. He's the Associate Professor and Head, Department of Radiation Oncology, Uttar Pradesh University of Medical Sciences, Safai, Etawah. Dr. Kailash, it's over to you.
Good evening, Saling sir. Good evening, Madhuk sir. Good evening, Dr. Surabhi, and to the whole house. So it is my pleasure that I have been invited by the course coordinator for this course, for this online class. Now I'd like to take pleasure to introduce Dr. Ajeet Kumar Gandhi. He is a associate professor in RML Institute of Medical Sciences, Lucknow. He has got a very good knowledge of his subject and is a very popular radiation oncologist in India and of course in UP. So he will be dealing with the topic of what is the role of radiotherapy and its techniques in oral cavity cancers. This is a very important topic as far as our part of India is concerned because it is one of the most commonest oral cavity cancer is one of the most commonest head and neck cancers, particularly in Uttar Pradesh, because the people here they have a habit of chewing tobacco, khani, gutka, and all those tobacco related cancers in which chewing or the tobacco is in contact with the mucosa, they are more common and they lead to oral cavity cancers, which are more common in Uttar Pradesh. While in other states, I have seen that, like in Haryana or Punjab, there people smoke tobacco, like in form of BDs or hookahs, and they have the posterior, the throat or the oropharyngeal cancers, they are more common. So now I would like to hand over to Dr. Ajeet for his presentation.
So thank you very much, sir, for the introduction. And I would like to straightforward jump onto the presentation and thank the organizers for giving me this opportunity to be here. And today we will talk on the basically radiotherapy management of oral cavity cancers. But I thought it would be incomplete to jump on to just radiotherapy part before, just giving us before having a brief on the oral cavity cancer. So oral cavity cancers, they approximately comprise of 10% of all cancer cases in India. And if we see the head and neck cancers in total, that would be around 20-25% of all cancer cases. The male is to female ratio is 70:30, indirectly, indicating the burden of tobacco, particularly smokeless tobacco use among the male population. If we see the NCRP data from ICMR, only 25% of these patients would have a localized disease. Localized, I mean just localized to the primary site of the disease. For example, if it is a tongue, then localized to tongue only without any regional lymphadenopathy. 65% would be around locoregional. And as we understand from this data that, which is also true there, is distant metastasis accounts only for say 5 to 8% of patients at presentation, and oral cavity cancers are mostly a locoregional disease, which has implications on its management as well. So very basic thing, the subsites of oral cavity. So there are 6 subsites of oral cavity: lip, tongue, the floor of mouth, alveolar ridge, the RMT, buccal mucosa, and the hard palate. The important point before understanding this subsite of oral cavity is because each of these subsites may have a different kind of lymphatic dissemination, which would have a bearing on the type of surgical treatment, on the type of design of radiotherapy portals. Just for example, cases of lip, if it is a central lip tumor, which is just a T1 tumor, it may not have much of a lymphatic dissemination. The larger tumors may have a lymphatic dissemination, particularly in the submental nodes. The upper lip tumors may have a dissemination in the, the facial nodes, the parotid nodes, which should always be kept into the mind. So while we are planning a surgery or radiotherapy portals, we need to have a knowledge about the lymphatic dissemination of different subsites of the oral cavity to help us. So moving on the same thing, to understand the lymphatic drainage better, we see that most commonly in oral cavity cancers, mostly there would be a level 2, level 1B or level 3 lymph node. If it is a well lateralized lesion, particularly true for buccal mucosa, retromolar trigone, even for early T1 tongue cancers, mostly the nodes that we see are ipsilateral. Contralateral spread may be there, particularly in positive lymph node patients, mainly because these lymph node masks produce lymphatic obstructions with a retrograde flow of lymph. And we have to be very cautious in patients where we are dealing with a recurrence after a prior surgery, because a history of previous surgery would cause, aberration of lymphatic pathways. And even if the lesion is well localized in a post-operative case, particularly those having a recurrence after post-operative period, would mandate, treatment of contralateral node as well. The lymphatic dissemination is also proportionate to the T size. So higher is the T stage, more is the lymphatic dissemination, and it also varies as per the site. For example, for oral tongue, if it is a T2 disease, the incidence of node positivity, incidence of clinically detected nodal metastasis may shoot up to around 30%. Compare this with a floor of mouth where T3, T4, and sequentially, if we progress on the T size, the number of lymph nodes rises. If the size of the lymph node increases, again, the chances of that node getting positive is more. For example, if the size is just 1 centimeter for the node, then the chances of it being a percent positive is just 33%. But if the size is more than 5 centimeter, then the chances of it being positive is around 100%. So this will have an implication when we discuss adjuvant radiotherapy with just one node, one nodal involvement, and there has been some change into this. It would be again good to emphasize that a good clinical examination for early oral cavity cancers is the best modality of assessment that we have. And many a times for a T1 lateral border of tongue, or maybe T1, T2 accessible buccal mucosa where we can palpate and assess it properly, maybe there is no need for having a local imaging. And I think palpatory findings are the best, gives us the best judgment to maybe proceed for definitive treatment. For rest of the oral cavity subsites, contrast enhanced CT is preferred. MRI gives a better contrast visualization, better delineation, as we see in this particular slide. The tongue lesion is better visualized on MRI. Had it been a CT, then the delineation would have been less prominent. PET-CT does not have a routine role in the initial evaluation of oral cavity cancers. However, in recurrent tumors, PET-CT does have a role there. And in select patients where, we find that the lymph nodes are not setting into the pattern of dissemination. For example, if we have a level 4, level 5 lymph node, although skip metastasis are said to happen in tongue cancers, or if there are lower nodes which are larger in size, 5-6 centimeters, then at that time, PET-CT may have a role to play in the evaluation of oral cavity cancers. And it's a must to send the patients for a pre-radiotherapy dental prophylaxis, whether we are treating in definitive or adjuvant setting. So what are our treatment goals for cancers of the oral cavity? Obviously, the first treatment goal we all harp on is cure. Second, also because oral cavity is an area which is very cosmetically sensitive. It's very difficult for the patients in the aftermath of treatment. So we also have to have a preservation and restoration of form and function. minimize the sequelae of the treatment, either be it surgical or radiation morbidities. And if we do not have to encounter advanced disease, then maybe palliation of the disease where it is incurable. And when we keep all these things in mind, there are a number of factors we also have to take into account. For example, age, general condition of the patient, performance status of the patient, previous treatment that the patient has received, and there's several tumor factors which will guide us to appropriate management, which will be discussed in the subsequent slides. Ultimately, at all times, we need to keep in mind the complications, the cost, convenience of the patient, the competence of treatment modalities, as well as the compliance to ultimately get a good result. A general conception is if we are dealing with a stage 1 bar stage 2 disease in oral cavity cancers, a single modality treatment, either surgery or radiotherapy, is effective and preferable. There are few exceptions to this. Some sites, like maybe oral cavity cancers, may have a higher risk of local recurrence, where even in stage 1, 2, we have a combined post-operative treatment as well. But barring a few exceptions, the general rule fits in that stage 1, 2, we have a single modality treatment. While in stage 3 or stage 4, a multimodality therapy is essential, mostly in the form of surgery along with post-operative radiotherapy with concomitant, with or without concomitant chemotherapy, and in some cases where surgery is not feasible, definitive radiotherapy with or without concomitant chemotherapy may also be tried. So moving on to surgery, it's important to know how the surgeon has performed the surgery, the extent of surgery, how the neck was addressed, what reconstruction techniques have been used, because it all gives us the information for a good radiotherapy planning for the patient. So surgery comprises primarily of 3 parts: the primary surgery, management of neck, and reconstruction. The primary surgery usually entails a wide local excision with a margin of around 1 to 2 centimeter, whatever is feasible in that particular area. If the disease is more advanced, then a composite resection, particularly patients with mandibular invasion, where either a segmental mandibulectomy is needed, a commando surgery is needed. Neck, essentially it could be either elective neck dissection or therapeutic neck dissection. And then there are types of neck dissection, which is supraomohyoid, modified neck dissection, radical neck dissection. And for reconstruction, if it is a smaller defect, then skin grafts can be useful, or larger grafts may be required, like PMMC or deltopectoral. Now we have radial forearm free flap grafts, which are good. Several approaches to know how oral cavity cancers are approached by the surgeons. While an early lesion may be accessed just with a per oral route, advanced lesions might need different kind of flaps, which needs to be raised before it could be accessed. A segmental mandibulectomy, where the part of entire mandible is removed, or a marginal mandibulectomy, where only a portion of the margin is involved. And in general, if there is just a mucosal abutment, then periosteal stripping is just done. If it is adherent to mandible but grossly not invading it, a marginal mandibulectomy would suffice. And if it is a gross cortical invasion, then segmental mandibulectomy has to be done. So we need to go through the post-operative discharge summary and understand what kind of surgery the patient, what kind of approach was taken, so as to understand the basic post-operative anatomy when we are sitting with the post-operative scans for delineation of tumor bed and other things. So that should be important. A word on surgical margins. In general, traditionally, it is said that the clear margin is more than 5 millimeter, the closed margin is 1 to 5 millimeter, and the positive margin is either less than 1 millimeter or cut margin positive. So positive margin is definitely a bad thing, but many times what happens is surgeon, goes in during intraoperative period, does a frozen section, and then revises the margin. And then since the report comes as the revised scent margin was clear. There has been a meta-analysis to this effect, and there are several other studies to support that the revision of the initially positive margin to clear based on the frozen section guidelines does not equate to an initially negative margin. So we need to understand that those patients where a revision has been done to achieve a clear margin are maybe going to do worse as compared to patients who has initial clear margin. Also, there is a contentious issue in the close margin group 1 to 5 millimeter, where there are studies which says that suppose if it is a 4 millimeter margin, that patient is probably going to do well as compared to someone who is having a 2 millimeter margin. This is a gray area. We do not exactly know what to do when there is just one factor of close margin and all other factors are negative. So neck dissection, we discussed selective and comprehensive neck dissection. So the term comprehensive neck dissection would be, it would remove all the lymph node groups as is there in R&D, and it could be any of the modified neck dissection, extended neck dissection, basically for advanced disease. When we look at the histopath report, it is also important to understand which sometimes we miss to see that how many lymph nodes have been dissected. That number of lymph nodes dissected is important to, and it has got a prognostic value. So a minimum of 18 lymph nodes dissected has got a prognostic value. And even if the patient has got a node negative status, patients who have got a 15 to 18, lesser than 15 to 18 lymph nodes dissected have got a poorer disease-free survival. In patients who are having a node positive disease, in them again, 18 to 26, there are other studies which says a higher number, but 18 to 26. So rough, we can remember that irrespective of node negative or positive, if 18 lymph nodes have been dissected, we can assume safely that a good neck dissection has been done in that particular patient. So recently, a couple of years, maybe 2020, this ASCO clinical practice guideline, a very nice summary of the guidelines for post-operative oral cavity management of neck has been published. So this is regarding the elective neck dissection. So if the disease is T1 oral cavity and the nodal status is N0, so ipsilateral elective neck dissection should be done. So this says that all the patients of oral cavity cancers, irrespective of their T size, ipsilateral elective neck dissection should be done. And this is got a backing from the TMS Dr. Anil De Cruz sir's NEJM paper, where it says that elective neck dissection definitely has an advantage over wait and watch policy. Very selected, highly reliable patients where, it's just a 1 centimeter tumor, patient has been operated outside, have a good neck dissection. There are no other factors for giving adjuvant radiotherapy. Then the neck dissection might be foregone and patient can be put on close surveillance, and later on a therapeutic neck dissection may be done if at all required. But for more advanced lesions like T2 to T4, all patients should have a ipsilateral elective neck dissection. And this ipsilateral elective neck dissection should include level 1 to level 3. In patients who have got a clinically node positive disease, ipsilateral therapeutic neck dissection has to be done, which would be level 1 to 4, and 5 may be included if there is a multi-station disease. And elective contralateral neck dissection is offered in tumors, particularly of oral tongue, floor of mouth, that is T3, T4, or approaches midline when the contralateral neck is negative. And therapeutic contralateral neck dissection is done if there is a node in the contralateral neck. So basically, it's a good summary of how the neck should be approached, which patients should be offered elective therapeutic, and what levels has to be addressed. Now, in patients who are not upfront resectable, generally they are a bad group of patients, and there is some kind of subjectivity also there. in patients who are deemed suitable for resection or not, it may vary from center to center. This is a study from TMH, and they basically took a group of patients which were considered to be technically unresectable to begin with. Like, for example, you see buccal mucosa primary with diffuse margins, peritumoral edema going up to or above the level of zygomatic arch, tongue primaries with tumor extending up to or below the level of hyoid bone. So technically, these patients would have been have difficult resections when they would have been taken up for upfront surgery. So these patients were given 2 to 3 cycles of induction TPF, and around close to half of these patients had sufficient reduction in tumor size, 43% of them, and they underwent surgical resection, and after surgery again receive adjuvant radiotherapy. So typically it was a trimodality therapy, and obviously the survival and local controls were better. So a select group of patients of very locally advanced, technically unresectable may be taken up for neoadjuvant chemotherapy followed by assessment, although not a standard of care treatment, but yes, it can be tried. Then in patients who have got either no options for induction chemotherapy and those who are considered upfront unresectable, there is an option of treating these patients with radical concurrent chemoradiotherapy. Obviously, the outcomes would be limited, and this has to be discussed with the patient. So coming to radiotherapy proper, so radiotherapy is delivered in different settings in oral cavity squamous cell cancers. It could be adjuvant, radical, or palliative radiotherapy. Brachytherapy has a role therein as either a boost or brachytherapy alone. And if we talk of EBRT, then several methods like conventional 2D RT, then 3D CRT, IMRT, VMAT. Under the banner of brachytherapy, we have interstitial brachytherapy and surface mold brachytherapy. So once the patient has undergone a surgery, and this is for understanding that oral cavity cancers are primarily a surgical disease to begin with, and all patients who are technically resectable, barring a few which we will discuss, would be taken up for upfront surgery. And after the surgery, we will have a histopath report. And if there is a involved surgical margin, R1 or R2 are rare, but there could be R2 resections, particularly in difficult to resect tumors going to high ITF or pterygopalatine fossa disease with RMT disease, close margin, depth of invasion. Now, depth of invasion, earlier we used to take the tumor thickness for tongue as more than equal to 4 millimeters. For buccal mucosa, less defined, but generally tumor thickness of more than 7 to 8 millimeters, or someone would say 10 millimeters, would merit adjuvant postoperative radiotherapy. Nowadays, the depth of invasion criteria has changed and the meaning has changed. We would discuss in subsequent slides what to do with the DOI that we are encountering in our post-op histopath report. Advanced primary disease like T3, T4, PNI or lymphovascular space invasion. And if the number of factors are more rather than just one, then the chances of again recurrence increases. Now, nodal disease with extracapsular spread is an indication. More than equal to 2 lymph node positive is a definite indication for adjuvant radiotherapy. Now, one lymph node positive is debatable factor, particularly if no other primary factors are present. But if one lymph node positive has got a nodal size which is more than equal to 2 to 3 centimeters, some studies would say if it is more than 1 centimeter, that's a gray area, then adjuvant radiotherapy would be given. But there would be a select group of patients with no adverse features at primary and just a single lymph node positive in the neck, which may be not a very routine scenario, may skip adjuvant radiotherapy. CTRT standard that we follow is margin positive, extranodal extension. These two indications we follow. And there are other factors like multi-station lymph node involvement, more than 2 or 3 factors for adjuvant radiotherapy. There are studies which says that there is a benefit and it has to be an individualized decision in patient to patient. Concurrent chemotherapy, the standard is 3 weekly cisplatin 100 milligram per meter square. Practically, we use weekly cisplatin 40 milligram per meter square, but we have that trial from TMH published in JCO where patients of post-operative head and neck were randomized to 30 milligram per meter square versus 3 weekly 100 milligram per meter square, and it was found to be inferior. So if we are giving weekly, maybe 30 milligram per meter square, we should not give. That is inferior to 3 weekly regimen. So this is what we were talking about, the depth of invasion. So this is the famous Ibrahimi paper. So we all know that depth of invasion is a different criteria rather than a tumor thickness, which is measured from the normal adjoining basement membrane, and then from there a plumb line is drawn to the most infiltrative depth of area of the tumor, and this gives us the DOI. So DOI could be different, even if this tumor looks, very proliferative kind of thing. But if we see the DOI in this, the DOI would be less as compared to the tumor thickness, which would be measured. And in this analysis, which was a multicentric retrospective analysis, it was found that the DOI more than equal to 10 millimeter was an independent prognostic factor for disease-free survival in patients of oral cavity cancers. So if a patient has got a DOI more than equal to 10 millimeter, by recent classification, it automatically becomes T3. So that's an indication for adjuvant radiotherapy. Now, if the patient has got a depth of invasion between 5 to 10 millimeters, it's difficult for us to say at the moment what we should do. Deriving extrapolation from the earlier thing, if it is a tongue, one would intend to give radiotherapy rather than wait, because tongue has got a failure pattern which is more worse as compared to buccal mucosa. This is another paper which assesses the impact. Many of you may be seeing these in the histopath report: worst pattern of invasion, tumor budding, tumor infiltrating lymphocytes. The exact implication of this is particularly on the effect of radiotherapy is not yet known. But in this study, they basically classified, worst pattern of invasion 1, 2, 3, 4, and 5, and then they clubbed 4 and 5 to a high risk worst pattern of invasion. And they did find that patients who are having a higher worst pattern of invasion had a more chances of mortality related to oral tongue, related to the disease. Also, patients who had a higher tumor budding, patients who had got a higher tumor depth, they all had a worse outcome as compared to their counterparts. So these newer parameters like worst pattern of invasion, the tumor depth, the tumor budding, they do have an implication on the prognosis. But if only one of these factors alone is present in the postoperative HPE, whether we should irradiate is not yet clear. But most of the times what will happen, as we also encounter, is patients who are having a worst pattern invasion are higher on the high risk side. Usually they have associated high risk other features, like they may have PNI, LVI, a higher depth of invasion, other things to guide the therapy. So additional recommendations from the guideline is adjuvant radiotherapy should not be given, and this we discussed, to pathological node 0 or single pathological node positive without ENE. So this is what we discussed, that single lymph node positive may be observed provided if there are no primary characteristics. In clinically N0, elective neck dissection is preferred, but sometimes we may encounter a patient like there is a T1 tongue cancer has been operated in a peripheral center. Just a wide local excision has been done, a good wide local excision has been done, but then patient referred themselves to a higher center, and there you find that with all palpation, imaging, and everything, the neck is clear. You do a high risk ultrasound, and everything is clear. And now there is a confusion whether to go in and do elective neck dissection or elective radiotherapy. So both are, acceptable options in this case. So elective neck dissection is preferred, but elective radiotherapy may also be given in that situation. And if only ipsilateral neck dissection is done, substantial risk of contralateral nodal involvement, particularly In patients with oral tongue or floor of mouth that is T3, T4 or approaching midline, then contralateral neck radiotherapy should also be given. A word about the overall treatment time. So it's very important to start adjuvant radiotherapy as early as possible, preferably within 4 to 6 weeks after the surgery, and probably when the healing has occurred. Local controls are better when the entire overall treatment time is uh, less than 100 days. Local control is worsened by approximately 9% with every week's prolongation of radiotherapy. Dose in the radical setting, it's around 66 to 70 gray, and we will see in the coming slides if in the intermediate risk areas we give a lower dose, and in the low risk areas we give a 54 gray. We might treat these patients with concomitant boost. If we are using brachytherapy as a boost, then maybe 21 grays combined with a 40 to 50 gray of external beam. In select patients of patients where we use brachytherapy as the sole modality, we might use 45 to 60 gray at 3 to 6 gray per fraction, but we prefer to keep the dose per fraction as less as possible, like around 3 to 4 gray per fraction, depending on the tumor volume. Larger tumor volumes would tend to keep the fractionation to around 3 gray per fraction, smaller maybe 4 gray per fraction. In the adjuvant setting, which we commonly encounter, 60 to 66 gray, and it has been found that there is no dose response beyond 57.6 gray, except in patients with an extranodal extension. So again, in patients, we generally give 60 gray. In areas where there is extranodal extension, margin positive disease, we might escalate focally to that particular area to 64 to 66 gray. And in a patient where we might need to give a lesser dose, or patient is not compliant, around 56, 57 gray may be enough in these patients. One of the problems in these patients happens is maybe the patient is eligible for a concomitant chemoradiotherapy, but the patient is not suitable. This is particularly important for the residents to understand that cisplatin, although it feels like a very simple drug to use, but it has got an added morbidity, particularly with radiotherapy, particularly in the post-operative setting. So whenever we are choosing concomitant chemoradiotherapy in the adjuvant setting, then we need to understand that it could have implications. This is a nice paper, and I would urge everyone to go through it to understand cisplatin ineligibility. So what do we do if the patient is cisplatin ineligible? In the definitive setting, there is evidence to use carboplatin plus 5-FU instead of cisplatin. The doses are slightly different. That is 70 milligram per meter square for carboplatin and 600 milligram per meter square for 5-FU. We could also use cetuximab weekly, paclitaxel carboplatin, which has a category 2B recommendation from NCCN, and nimatuzumab can be used single agent weekly, but it's just an extrapolation from the TMH phase 3 trial where cisplatin was compared to nimatuzumab plus cisplatin, but there are some retrospective data to support. So I would just say it's an experimental thing to do, not recommended routinely. In the post-operative setting, we have the data from RTOZ 0234, where patients were randomized to cisplatin versus cisplatin plus cetuximab versus cetuximab plus docetaxel. And extrapolating from that data, if the patient is cisplatin ineligible, then there is one regime which is cetuximab plus docetaxel, which can be given in this particular patient subgroup. This is also recommended by NCCN. Now, when we are delivering radiotherapy to a head and neck area, there are several challenges, which includes immobilization, setup uncertainties, volume delineation, delivery, and other things. So this immobilization and other things, it is generally similar for both 2D conventional planning or advanced planning. We need to be more accurate for the advanced planning. So the immobilization is usually done with either of these casts, thermoplastic casts. appropriate headrest has to be there where the patient is comfortable, particularly in cases where tongue post-op, hard palate, upper alveolus. We may insert a bite block to separate the tongue from the upper areas, or in case of hard palate from the lower tongue, and spare it. This is one of the patient where we had used a bite block and then did a simulation scan. You can nicely appreciate that how the hard palate and joining mucosa is pushed up, and it would be saved during the treatment planning. It's important also to wire all the scars that we see in the post-operative period. And if we are, treating in the definitive setting and there is an N3 node, a clinically extranodal extension is present, we need to bolus that particular area to have a good dose distribution, because many of times we are treating with a mega voltage energy, which might lead to underdosing of the particular area. In post-operative setting, if there is a margin positive disease, then particularly the skin, in the context of skin margin positivity, you might need to bolus the scar. So to understand the two-dimensional conventional planning, there are certain landmarks which we need to understand. This is the zygomatic arch, and this is the upper border of the zygomatic arch. And this is the hard palate, this is the soft palate, and this is the hard palate soft palate junction. This is the tip of C2 spinous process. This is the top of thyroid notch. And this is the junction of 2/3, 1/3 of clavicle. So generally, when we use a 2D planning, maybe a fluoro-based planning, or even on a TPS, when we use just conventional field borders to guide our treatment, these landmarks are important to identify, because most of the times the posterior landmark almost remains the same, varies in some case, we will discuss. The inferior border, if we are treating with a bilateral opposed with a low anterior neck, remains same, which is roughly at the level of top of thyroid notch. The lower border for the land also remains the same. There is a variation, particularly in the upper border of the field and the anterior border of the field, which we need to be cautious of and learn to understand 2D planning in oral cavity cancers. So a rough general principle is, when we are designing the portals for a superior border, roughly we need to keep in mind that the upper border is positioned such a manner that there is at least a 1.5 to 2 centimeter border on the tumor bed. Inferior border is generally matched with a low anterior neck field. If it is not matched, and if the patient is being treated just with two parallel opposed portals, then it should cover at least the nodal areas that we intend to cover. Anterior border is 2 centimeter in front of the primary tumor. Most of the oral cavity cancers, it would be usually in front of the mandible, with sparing of the lips in cases. The posterior border is kept at the C2 spinous process, but in cases where we do not need to treat level 5, the posterior border may be set at the mid-vertebral body with some sparing of the posterior part. So the general principle is, typically the patients would be treated with a parallel opposed upper field, which is matched to a low anterior neck field. Usually this is delivered in the first phase, and after the first phase, there would be a cord off phase where the posterior border is drawn anteriorly to put the cord off roughly after 44 to 46 gray. And if there is a positive cervical lymph node, high risk disease, the lower neck will also be treated after the first phase. And in that case, the land field would be, minimized to just one part, putting it off the cord, and then have been blocked and matched as before. The land would also have an anterior larynx block, which seals the central larynx from unnecessary dose. And also, we should be cautious, particularly in patients where we are dealing with a node positive definitive sitting, not to block the GTV while we are blocking the larynx. And if we are having a TPS based plan, then we would be able to see that. Uh, if we are using a uh, mega voltage energy, then 4 to 6 mega voltage is preferred. Higher energy should be discouraged. And even in with these energies, sometimes we need to use a bolus to correct for this. One of the problems with 2D planning, particularly if the patient is being treated with a cobalt 60 rays on a daily cobalt radiotherapy machine, those of you who are working in a cobalt setup must be familiar with this. Those who are not, for them it's just a brush up that once the field borders are marked on the, or if it cast on a conventional simulator, then it is sent to the mold room. There is a jigsaw which is set over there, and with a a small pointed rod kind of thing, the different depths are measured at different levels, and with the help of the small aluminum blocks, this is a compensator which is known as a 2D compensator is made. And this 2D compensator is fitted like this, with the compensator facing towards the patient into the slot which is provided on the cobalt head. So usually compensator is recommended almost in all patients, particularly if the variation of the depth at different levels, say for example, the upper border, the mid and the lower is more than 2 to 3 centimeters, then a compensator must be made. Otherwise, we are likely to land up in more of radiation toxicities. So now individually seeing the design of field borders, for example, this is a field border for a oral tongue, where the upper border has been kept as at the soft palate hard palate junction. The anterior border has been just kept anterior to the mentum, sparing the upper and the lower lips. The posterior border has been kept at the C2 spinous process, and this has been matched with an low anterior neck field with a midline block. Now, this upper border is just going to change. Suppose if we are using a retromolar trigone, which is likely to be situated in this particular area, then as we saw, the general principle is 1 to 2 centimeter above the tumor bed. So in the case of retromolar trigone, the portals would remain same, but the superior border would go around 1.5 centimeters to 2 centimeters above the hard palate to cover the tumor bed. The posterior border, if we are treating level 5 till level 5 lymph nodes, then it would be here. In cases where it is a good dissected neck, N0 neck, and we do not intend to treat the posterior part of the neck, then maybe mid border of the mid vertebral body, we can drag the posterior border as well. The inferior border remains the same. In case of buccal mucosa, the upper border is at the upper border of zygomatic arch. We also need to wire the scar to understand we are not missing anything. Particularly if it is a high up buccal mucosa cancers, then maybe sometimes it may need to be dragged a bit more further. Particularly in cases where there is a high ITF involvement, ITF clearance has to be done, then it would go maybe 1 or 2 centimeters higher than this. We also have an opportunity to treat buccal mucosa with an ipsilateral irradiation, because well lateralized buccal mucosa would have a limited dissemination to the contralateral side. So there are two ways to treat this. Either you treat using an anterior and ipsilateral wedge pair photon fields with a 45 degrees wedge. The lateral borders would be same as we are using in this. The anterior border, anterior field would be the medial border 2 centimeter beyond the surgical margin, lateral fall off in the air, and superior inferior border corresponds to the lateral field. Now, when we do a treatment planning system based plan, maybe 3D CRT, or even just draw this and just put the beams, then usually we use a oblique parallel opposed wedge paired field, which leads to a good coverage and also spares the adjoining, particularly the contralateral part of the entire buccal mucosa, parotid, and also the organ at risks. So hard palate and alveolar ridge, the posterior inferior borders would essentially remain the same, and the anterior superior borders would be 2 centimeter beyond the surgical bed. So when we are planning a 2D, the basic, general guiding principles we need to understand, and I think that should be helpful enough to design a two-dimensional radiotherapy portal. Now, when we talk of a conformal radiation planning, there is a bit of complexity into this. Immobilization would remain the same. Essentially, we would acquire a planning scan, would contour the target volumes, normal structures, and then take it to the treatment planning system, put in beams with the physicists, and then evaluate the plan, approve the plan, see the setup, position verification, dose verifications, and all this has to be done with a conformal radiation plan. When we proceed for a conformal radiation planning, it's important for us to delineate the organ at risks as well as the target. So organ at risks are like brainstem, optic structures, spinal cord, mandible, brachial plexus. Essentially, it would depend on which kind of site we are going to treat. For example, uh, mm, for a tongue IMRT, maybe the optic structures are not required to be drawn. But for a buccal mucosa primary, where we are treating a higher up zygomatic, higher up infratemporal fossa, then we need to delineate the orbital structures. It's a good practice to draw the organ at risk. So the different organ at risks are to be drawn. Uh, um, in certain group of patients, we might have also a opportunity to spare the constrictor muscles, which is not a routine thing to do, but sometimes we do this as well, where here you see the superior constrictor, middle constrictor, inferior constrictor, the cricothyroid, the cervical esophagus part, the glottic, the supraglottic larynx, which has all been drawn as an organ at risk. Coming to the target volume delineation, I hope all the residents who are here are aware of the GTV, CTV, and the PTV concept. Those who are not familiar, so the gross tumor volume is just the and the palpable tumors. CTV is a microscopic extension, and PTV, encompasses internal and setup margin. So when we are treating the patients in the definitive setting, we first draw a GTV, which is primarily the gross disease, including the neck nodes. Then we draw a CTV, which is essentially around a 5 millimeter of margin around the gross disease. We have got an intermediate risk CTV, which encompasses the high risk CTV with an additional margin of around 1 centimeter. Obviously, it needs to be edited from air, the bones, the areas where the tumors cannot penetrate. And then we have low risk CTV, which includes ipsilateral or contralateral involved nodal levels with lower risk of subclinical disease. In case of post-operative, again we have a high risk volume, which is tumor volume with a CTV 66. So as we discussed, the 66 dose is usually delivered into the areas which are either microscopically positive, which has significant soft tissue or bone invasion, otherwise, and also areas with an extracapsular extension. Otherwise, this CTV 66, if these factors are not there, will not exist. Then there will be only 2 volumes. CTV 60 would be the entire, pre-operative tumor bed. In neck, it would be a preoperative gross disease, adjacent ipsilateral, contralateral. We'll see which lymph nodes level groups to involve. So, for example, in this case, it is an oral tongue where the entire tongue as well as the base of tongue has been taken into the CTV. Sorry, the tumor bed, because the tongue has been resected. In the buccal mucosa, the entire tumor bed has been taken up. There are some recommendations which say that we do not need to take the entire buccal mucosa muscle, the buccinator, as well as the adjoining subcutaneous tissue, particularly in cases where we have got an early lesion like T2, and there are other indications for adjuvant radiotherapy. But otherwise, the entire tumor bed along with the buccal mucosa and adjoining muscle has to be taken into the tumor bed. The other remaining areas would comprise of organ at risk, and here we see there is a high risk CTV, intermediate risk CTV, and a low risk CTV on the opposite side. So which lymph nodal groups to treat? If it is an oral tongue and floor of mouth, typically we treat bilateral 1 to 4 because Floor of mouth and oral tongue are, considered to have a much more lymphatic dissemination. Uh, in patients who are node positive, we definitely treat bilateral level 1 to 5. In buccal mucosa, however, the situation is slightly different, where in negative patients which are well lateralized, we may treat ipsilateral 1 to 4. Even in node positive patients, we may treat on ipsilateral side level 1 to 4 and include just contralateral in cases where tumors are approaching either midline, extracapsular extension is there. Uh, it has to be an individualized decision. But there are many centers, including myself, we do not routinely use contralateral neck irradiation in buccal mucosa. In RMT, heart palate, and gingiva, if it is a lateralized lesion, then ipsilateral level 1 to 4 would be sufficient, and in node positive cases, contralateral may be treated. So to take you through two cases, this is a T4A and 2B oral tongue, which was deemed unresectable, and this is being treated with a definitive radiotherapy. So you see the red portion, the inner one is the GTV 70, which has included the almost the entire tongue, the base of tongue. Also, the involved lymph nodes have been highlighted in GTV 70. The high risk CTV 59.4, which is seen in in the green color, includes the ipsilateral level 1 to 5, and the low risk includes the contralateral neck, which is in the blue color. So we have to treat both the neck, level 1 to 5 in this case, and the primary tumor area. This is a case of retromolar trigone with T4A and 2B. This was resected surgically. However, there was a medial pterygoid involvement and a bit of positivity in that particular area. So this has been marked as a high risk CTV, which is going to receive a higher dose of 66 gray or maybe 70 gray. It only localized to this particular area, but 66 gray is good enough. And the adjoining, we have the red color, which is high risk CTV, and the neck area, which is bilateral neck area, which is low risk CTV. Coming to brachytherapy. So brachytherapy does have a role in oral cavity cancers. Particularly, it could be employed as a sole treatment for T1 and small T2 tumors. And by small, we mean, usually less than 3 centimeters of tumor. Also, in certain cases, cosmetically sensitive area where surgery is likely to be more disfiguring, lip and angle of mouth cancers. It could be utilized as a boost treatment for T1, T2, and small T3. And brachytherapy has also been used as an adjuvant treatment where surgery has been combined along with either perioperative or post-operative brachytherapy, particularly for recurrent tumors where standard surgery is likely to cause a significant loss of function. However, all patients are not suited for brachytherapy, and there are patients who have comorbidities because it has to be done under anesthesia. So patients who are not fit for the procedure has to be excluded. The tumor should not be abutting the bone because then brachytherapy is not going to cover this, and if we intend to cover this, then the bone is going to get a very high dose. If we are not accessible tumors, then it would be difficult to perform brachytherapy procedures. So there are some contraindications as well. So what we'll see is we'll go through a step by step for a brachytherapy procedure of a oral tongue patient. So this is a well lateralized lateral border of tongue, left lateral border of tongue tumor, which is approximately 1.5 cross 1.5 centimeters, and it was taken up for definitive brachytherapy. So during the procedure, first we obviously patient is under anesthesia. We achieve a good exposure of the patient, and then we mark this particular tumoral area with around 1 to 2 centimeters with an blue ink to define our area of implantation. Then under by manual palpation, we start inserting needles through the neck, and it would come up here in the tongue. And once that needle has come up, then we thread the plastic in a flexible brachytherapy catheter tube onto this, and then again take it out on the opposite side of the neck. So we do it sequentially, and then the two planes has been placed, and finally this is the completion of the procedure, and this is the dosimetry of the same patient. This is how the treatment is delivered with in the uh, brachytherapy, with the brachytherapy machine. This is another patient which was treated with a brachytherapy boost at our center, and this was a fairly large tumor, but it was patient was not given clearance for surgery, so we did brachytherapy boost along with external beam radiotherapy with concomitant chemotherapy, and this is the treatment follow-up picture. The patient has almost completed 3 years of follow-up now. Angle of mouth, as we discussed, as cosmetically sensitive area, this surgery would have again led to a disfiguring outcome in this case. And again, the same procedure, we mark the tumoral area with a 1 to 2 centimeter margin. And because of intense submucosal fibrosis, which we can also appreciate in this particular figure, we could only do a single plane implant, although it is preferable to always use 2 plane implants, but we were not getting enough space to put in. So we just converted it to a boost treatment, and we delivered boost treatment with this and followed by external beam radiotherapy with concomitant chemotherapy. Patient is also doing good. Alveolus superficial tumors like this may be amenable for a surface mold brachytherapy treatment, where this kind of customized prosthesis is made along with the brachytherapy catheters, and that's it. So when the patient has completed the treatment, the patients are now put on follow-up, and the major goals of surveillance is early diagnosis of recurrence and also second primary tumors, because we know that as the patients would progress into their follow-up period, more the time passes, patient have got around 30 to 40% sometimes in combine the entire head and neck chances of developing a second primary tumor. So we have to identify that early so that the management can be done. A routine head and neck examination is must for all the patients who are coming to us for initially 3 to 6 months in the first year, after 2 years every 6 months, and thereafter yearly for next 5 years or so. Imaging is not a routine thing to do, particularly for oral cavity cancers, particularly if it is an accessible site, for example, a buccal mucosa, which is accessible to palpation. In a routine follow-up, we do not use imaging, but we do it if it is required. Continued, dental evaluation, tobacco cessation, rehabilitation, counseling of the patient to finally bring that patient back into the societal life. It's also recommended to get a TSH level every 6 to 12 months. There are we do this practice, and we do come across patients who are having hypothyroidism and they are on thyroid supplements. So to conclude, the first management summary is for an early disease, which is T1, T2, and 0, a surgery is preferred. And resection of the primary is done, as we discussed, wide local excision with a 1 to 2 centimeter margin. With ipsilateral or bilateral neck dissection, we discussed the indications for this. And after the surgery, if it is a node negative patient with no adverse features, we observe the patient. If there is just one positive node without any adverse features, and that node is smaller in size, say less than 1.5 centimeters, we might put that patient on follow-up. But if that node is larger in size, then give the preference of giving adjuvant radiotherapy to that particular patient. If there is an extranodal extension, chemoradiotherapy. If there is a positive margin and there is a chance of re-resection, maybe patient can be asked to get a re-resection done, which in most of the cases are not done. So chemoradiotherapy again. And for other adverse features, usually adjuvant radiotherapy is given. And we discussed that if there are 2, 3, or multitude of these factors present, then there is a role of giving CTRT in this case as well, but that is to be an individualized decision. The same T1, T2, N0 patients treated with definitive radiotherapy, mostly if amenable for brachytherapy, then brachytherapy or brachy combined with external beam or external beam alone. And if on follow-up, they have no residual disease, they continue to follow up. And if they have a residual, then there could be again possibility for re-resection or systemic therapy. Advanced disease, T3, T4, node positive disease, again surgery, depending on the post of histopathology, adjuvant treatment, which essentially remains the same. And if these patients also have a contralateral neck node, then obviously bilateral neck node dissection has to be done. Now, patients who are inoperable, locally advanced oral cavity cancers, the options are limited. One of the options that we discussed is try in select group of patients, younger fit patients with good performance status, option of neoadjuvant chemotherapy followed by assessment for surgery, or use definitive chemoradiotherapy or definitive radiotherapy. In patients, again, guided by the patient's age, performance status, and other things, patient may not be suitable for all of these, and there we resort to an palliative intent of treatment. Thank you very much.
Thank you, Dr. Ajeet. This was a very informative and comprehensive class, you can say, and brushing up our knowledge as well as all the residents who have been watching these lectures. You have very nicely covered all the topics, right from the epidemiology to the risk factors and the type of surgeries and the nodal dissection, various indications of radiotherapy in definitive as well as in adjuvant setting and their advantages and disadvantages. And also the thing which is these days being less commonly used, that is the interstitial brachytherapy. I think we can take some questions now. There is one question from Dr. Swapnil Porwal to Dr. Ajeet. He may answer. He is asking that what is your experience with respect to osteoradionecrosis and how many patients have you seen with ORN post radiotherapy? Dr. Ajeet?
Yeah, so osteoradionecrosis is, a bad thing to happen to the patients. Most of the times this, needs to be minimized. And this is becoming, almost a rare phenomena, particularly with a good pre-RT dental prophylaxis that we routinely do for our patients. But yeah, often then very rarely we do come across. I had one patient where the patient has got mandibular necrosis and surgery has to be done. The patient did try for hyperbaric oxygen therapy, did not get benefit from this. And sometimes, it can be very distressing to the patient, and patient had to undergo, surgery for that particular thing. And I think patient did not turn up after that. So this is becoming increasingly rare. And the only thing I would say is the best treatment for osteoradionecrosis is to, prevent it from happening rather than deal with it once it has happened.
I think there are no more questions from the house. We can request Dr. Salin sir for his words of wisdom and his expert comments.
Can I put one question?
Sorry.
So can I ask one question?
Yes, sure.
Yeah, Doctor.
Dr. Ajeet, I just want to know how you titrate the dose of radiation in case of the mandibular prosthesis.
Mm-hmm.
Some metal prosthesis. So how you titrate those?
Usually we do not change our dose schedule based on the mandibular prosthesis. Most of the times these are not metallic prosthesis. Now surgeons have, resorted to the tissue prosthesis. Mostly it would be a fibular prosthesis that they're using. So metallic prosthesis are now increasingly being rare for mandibular reconstruction. Even if it is there, we do understand that it is going to have a more radiation toxicity, and it is going to interrupt and have got outcomes, toxicities which are higher than as compared to the other patients, but it's difficult to tailor our treatment or give less dose to that particular. So we just counsel the patient and go ahead with the routine intended treatment in that case.
Okay. My second question is in case of the lateralized tumor, like tongue, in the 2D planning, what will you prefer to give the weightage, beam weightage there?
No. So particularly for oral cavity cancers, giving Weem weightage, you mean that we uh, tend to spare a part of the uninvolved tongue. So
Yeah.
in essence, it becomes a partial tongue irradiation, particularly for early localized tongue cancers. But because tongue being a mobile structure, and in patients where we are giving radiation, there are definitely some high risk features, probably more so in the primary rather than the nodal areas. So this partial tongue irradiation is an experimental thing to do, and as of now, whenever we are giving adjuvant radiotherapy, we intend to cover at least the entire tongue, and in advanced cases, definitely the part of base of tongue as well.
Okay. There is one more question. Dr. Kailash, will you put up?
Yeah, this question is from Dr. Bhaskar. He's asking, in oral fistula, is radiation useful or not? Can we expect closure till what extent and size?
So you are typically, dealing with a disease which has got a skin infiltration through and through, and that would be a T4A disease. If it is a very small fistula, which is where there is no leakage of water or food, and it's maybe say 5 millimeters or less, most of the times we just give palliative radiotherapy in these cases. So their palliation does have a role, but in case of larger size of fistula, we tend to avoid it because it might aggravate the fistula again. But again, in the same patient scenario, we should not shy away from giving palliative radiotherapy by taking a diversion procedures like tube feeding, this thing for bleeding or something. Radiation would definitely benefit that particular patient. So it's an individualized decision, and it should not be a absolute contraindication for radiotherapy, particularly for palliation, because radiation does give a very good palliation as compared to we would try systemic therapy or something.
Any other questions from the house? Okay, now I would like to request Dr. Salinser.
Nothing really, Ajeet, and everybody else. Comprehensive without doubt. Oral cavity is very important for us, both when you get post-operative. It's a large bulk of disease, and one must know how to deal with it. I think one of the main challenges you face in clinical practice is that when you have T4 disease, trismus, and the disease is very extensive, there is, threatened fungation, skin involvement, poor performance status. The battle is the decision-making comes whether you should go all out and give full doses, or you should stop short and just give palliative doses. Typically, the way Professor B.K. Mohanty has shown us in his Green Journal paper, 20 grain 5 fractions, wait for a month, response is good, repeat it with another 20 grain 5 fractions. If the response is very good, you could take it to approximately 40 grain. Dr. Ajeet Gandhi can advise us more on this because he's from the same institute. But there are debates there. And of course, if you have fungation and large tumors with a tumor control probability that is really low, one then goes for metronomic chemotherapy or palliative chemotherapy. So, but this is something that can be learned and acquired, and this is a massive volume of work, volume for anybody practicing in UP. Ajeet, would you want to comment on your palliative regimes, particularly? Have you touched on those? And if you have, you want to elaborate on it?
So yes, there would be a certain subset of patients which we encounter, and these are bad group of patients where they have been refused surgery. These would be, unresectable T4A disease or N3 disease, which are very bulky node. And there we need to, initially first decide whether our intention is palliative, or we know, high palliation, or maybe we are inching towards curative treatment, obviously with discussion and everything with the patient sitting across. One of the regime for these patients where there is no fungation, it's just a borderline N3 disease. Palliative radiotherapy is one of the treatment options, and that too in a phased manner, as you said. Uh, as we used to practice in AIMS, is we give 20 gray in 5 fractions and then assess the patient after 3 to 4 weeks. There would be close to 25-30% of patients who would respond remarkably to this. And then maybe we are filtering out and bioselecting those patients for a more curative intent. And then in the second phase, we go in with a conventional fractionation rather than hypofractionating. There was yet another study which was done at AIMS from one of the medical oncology DM residents, where uh, concomitant cisplatin was also given along with palliative radiotherapy with a dose of 6 milligram per meter squared daily, uh, with 20 grays and 5 fractions. That result has been published, and it did say that the response rates were slightly higher, but not very conclusive ones. So these all are experimental approaches for treating such a patients. The third one would be, as I said, that is also experimental, is giving a neoadjuvant chemotherapy with an aggressive regimen like TPF in patients who are young with a good performance status, just a borderline technically unresectable disease. We can again bioselect, uh, take out, chunk out a patient subset where we can deliver more aggressive therapy later on. And lastly, the option of initiating the treatment on palliative chemotherapy with an metronomic or whatever, preferred is either a single agent therapy with either single agent methotrexate, single agent cisplatin. I would not harp on immunotherapy and other things, which is a lot more confusing. And then once the patients responds to this, there would be very few patients who would be again taken up for curative treatment. But then we can pitch in palliative radiotherapy later on and keep this as a reserve modality. So it's a very complex decision which we make in a tumor board or a multimodality teamwork, and also at the most importantly involve the patients and their relatives into the decision making uh, before we harp on any treatment like this.
Thank you
Dr.
very much.
Kailas, I can see two more questions there in the
Yeah,
chat box.
yeah, Dr. Ajit, we have got some late
Okay,
entries.
I'll see. Yeah, I'll see the question. So one of the question is post-op tongue squamous cell carcinoma, path T2, single risk factor LVI, role of adjuvant radiotherapy. So lymphovascular space invasion has been independently found to be a poor prognostic factor for particularly oral cavity cancers. I would say go in and give radiotherapy. T2 again for oral tongue is a bad thing, and most of the times you would see the DOI and the tumor thickness are larger in T2 disease. In tongue, I would say a general consensus or a general rule that we should follow, and we have burnt our fingers like that, and learned that whenever you are in a doubt, go ahead and give adjuvant radiotherapy rather than putting the patient on observation. That does not mean that we irradiate all the post-operative patients, but to err on the higher side rather than observing these patients because failures are high. The second question is dental extraction after RT, if at all, what time is advised? So it's the more is the time, the better it is, and better not to extract it. But 2 years or more, preferably more than 2 years, would be good. And that too, the extraction or any dental procedure has to be done under a expert dentist, not just a community practicing dentist. It has to be in discussion with the radiation oncologist. Maybe sometimes what would happen is patient would come with a dental pain, nagging pain, and with a pretext that it should not be extracted, and later on when we view the plan, we find that we had irradiated a buccal mucosa with a ipsilateral tumor bed and ipsilateral node, and the contralateral side was absolutely received no radiation, and that contralateral teeth is spinning. So take it out before 2 years, take it out within 2 months, 3 months, whatever it is, if you are sure that you did not deliver any radiation there. So you need to take out the plan, understand it, what doses has been delivered there, and then discuss it with the dentist that whether there are some non-extracting procedures available for this patient or not, and then take into account that time factor that we discussed.
Thank you, Dr. Ajeet. Thank you all the participants, especially Dr. Salin and Dr. Surabhi for organizing this class, and Dr. Ajeet for this wonderful presentation. I would like to thank you all the attendees for attending this class. So over to Dr. Surabhi now.
Yeah, thank you so much, Dr. Ajeet, for such a wonderful lectures, and you have covered very well 2D planning, which is usually not covered, and our students are very confused. Fletcher to Paris, you have covered all the things. Thank you so much once again. Thank you, Dr. Kailash, for moderating the session. Thank you, Salin sir, for your proper guidance, and thank you all the participants for joining us.
Thank you.
Thanks all.